to one and all. I'm Dr. Keval. I'm Associate Professor in Cardiology at UNMICRC Institute of Cardiology and Research Center, Ahmedabad. I'll be discussing on a very important topic, prosthetic heart valve thrombosis. Now, this is a topic which may not be relevant for people working in small centers and maybe where there are no cardiac surgical backup facilities, but for people like me working in tertiary care institutes, teaching institutes, this is a very important disease and one should be very well aware of the presentation and the treatment of this important entity. So as the term states, what is a prosthetic heart valve thrombosis? So any thrombus formation which may either be subclinical or it may be overtly symptomatic thrombosis of a prosthetically implanted valve. Now the total number of patients with valvular heart disease worldwide is approximately 100 million. What is the recent change is that the reduction, there's been a marked reduction in the incidence of RHD, but the degenerative valve diseases have increased considerably. The prevalence of mitral or aortic valve disease is approximately 2.5% in the general population, and the treatment for severely symptomatic valve disease is usually surgery. Although we know recently that transcatheter therapy in the form of TAVI or TAVR is now an upcoming modality for treatment of patients with severe aortic stenosis. So we have different types of prosthetic heart valves. We have biological valves or also known as the tissue valves, and then we have the metallic valves, right? So the metallic valves are, we have the bileaflet valve, the common one being the St. Jude Master Series SJM, and we have the tilting disc valve, single tilting disc, and then we have the ball and cage valve, right? And the tissue valves can either be percutaneous like the ones we do in TAVI, or they can be surgically implanted. Again, these tissue valves which are surgically implanted can be stented valves, or they can also be stentless valves. So metallic valves are bileaflet St. Jude valve, single tilting disc, it's a Medtronic Hall valve, and the ball and cage valve, which is also known as the Starr and Edwards valve. The biological or the tissue valves are the stented valves or the stentless valves, or the percutaneously implanted, the Sapiens valve or the core valve. The Sapiens valve being the balloon expandable valve, and the core valve being the self-expanding valve. Now, mechanical heart valve thrombosis is formation of any thrombus in the absence of vegetation attached to or near an operated valve that occludes a part of the blood flow across the valve. The incidence is approximately 1% per patient year in the high income countries, but in countries like India it's approximately 6% per year, right? 6% per patient year, which is considered to be very high. The risk of prosthetic valve thrombosis and thromboembolic events is obviously higher with a metallic valve as compared with a biological valve. The mortality of a prosthetic valve thrombosis is very high, especially in patients who come with NYHA class 3 or those who come in NYHA class 4 with cardiogenic shock. The peak incidence is around 1 year post implantation, and thromboembolic episodes may or may not originate from the prosthesis, but they have an estimated annual incidence of approximately 3%. So now let us look at something which is not very common before we go to the processes of a metallic valve. Now, bioprosthetic heart valves, we know that they are less prone to thrombosis because they are actually made from tissues, like they can be pericardial valves, they could be porcine valves, or they can be bovine valves, but most of these are either pericardial valves or autografts. So they tend to thrombose less as compared to the metallic heart valves, and they occur early in the postoperative period, particularly in the first month to the first 6 months after implantation. So amongst these valves, the risks of valve thrombosis are higher with a stented valve as compared to the stentless valve. In the partner 3 trial of TAVI, it has been shown that the 30-day incidence of prosthetic valve thrombosis is around 13% as compared to 5% with surgical AVR. Also, a sub-study of the Evolute series showed that the rates of PHVT with TAVI implanted valve at 30 days was around 17%, and at 1 year is around 30%. The factors which predispose to bioprosthetic heart valve thrombosis are an increase in the Doppler gradients, presence of atrial fibrillation, subtherapeutic INR, increased cuspal thickness, and abnormal cuspal mobility. So bioprosthetic heart valve thrombosis is less frequent. Also, the number of procedures which are done with TAVI are comparatively less in our country as compared to surgical valve replacements. So we'll be dealing mostly with metallic valve thrombosis. Now there are 4 different entities: thrombosis, pannus, degeneration, and endocarditis, which can present in a somewhat similar fashion. They may occur simultaneously, or they may occur. It may be a mixed picture. There may be a picture of endocarditis with some amount of thrombosis, and the determination of the exact etiology remains very important because your treatment is going to depend on your exact diagnosis. Now first let us understand what is the mechanism of PHVT or a prosthetic heart valve thrombosis. So it is a multifactorial problem. Virtuo's triad states that there are three main mechanisms of vascular thrombosis. So similarly, for a valve thrombosis also there are three major mechanisms. We have the surface factors, we have the hemodynamic factors, and we have the hemostasis factors. So the exact mechanism of development of PHVT is not clear. It may include a combination of some amount of thrombus, some amount of tissue overgrowth, some amount of fibrotic pannus, may have some component of a prosthesis mismatch. But the exact pathophysiology, even in many of these cases, may not be delineated, and we need to understand the cause for each of these conditions, and I would say that most of the cause is because of therapeutic under anticoagulation. Now let us look at the surface factors. So surface factors are basically related to the implantation of the valve. So if there is an incomplete prosthesis endothelialization, or if there is a leaflet damage, leaflet deterioration, or if there is a problem with a ring, then these are surface factors which predispose to development of valve thrombosis. The hemostatic factors include hypercoagulable states, tissue injuries, heparin-induced thrombocytopenia, and most importantly when the patient has an INR of less than 2. Hemodynamic factors which are important include anatomical position of the prosthesis, low cardiac output, or low flow states like on the right side of the heart. Right now, this I would say is one of the central slides of the presentation, where we discuss what are the factors which are responsible for the valve thrombosis. So let us look at the right side. Now we know that right-sided valves need a higher INR, and right-sided valves are more prone to thrombosis. The most important reason for a thrombosis of a pulmonic valve or a tricuspid valve include mostly the hemodynamic factors. So this is basically a condition where the blood flow is low, the pressures on the right side are quite low as compared to those on the left side, and that is why thrombosis of a metallic valve in either a pulmonic position or a tricuspid position are very high. So most of them have got to do with the hemodynamic factors, low blood flow. Some amount of hemostatic factors and tissue factors also play an important role, but most of the times it is going to be because of a low blood flow, presence of atrial fibrillation, presence of severe PH, which lead to a low cardiac output. Again, on the right side of the heart we see more of thrombi, we see more of clotting rather than the platelet aggregation, whereas on the left side of the heart it's more to do with the platelet aggregation and less to do with the clotting mechanisms. So on the left side of the heart, if you look at the aortic valve, so the problem with the aortic valve in most of the cases is related to the surface factors. So surface factors like incomplete endothelialization or damage to the leaflets or damage to the rings, or these are the factors which actually lead to aortic valve thrombosis. And we know aortic valve is the least predisposed to development of thrombosis. Again, mitral valve is something that is more predisposed to thrombosis because of a low blood flow and the low pressure in the left atrium. So in the mitral valve, again, your hemodynamic factors are going to be more important. Hemostatic factors like tissue injury also play a role, and the surface factors become the least important in the case of a mitral valve. So under anticoagulation is responsible for PHVT in around more than 50% of the cases. That is the most important factor. That is why the baseline INR is always required in patients who present with valvular dysfunction. Then poor cardiac output, presence of atrial fibrillation, pregnancy, hypercoagulable states, prosthesis malpositioning, hypereosinophilia, these are considered to be predisposing factors for valve thrombosis. So, but again, we have to remember that subtherapeutic INR is probably the most important cause of PHVT, and patients who say that they have been taking good dose or they are maintaining their INR, we always need to double check these cases, because in most of the cases you find that the patient may have missed a few doses of warfarin, and to cover that up he takes extra doses of warfarin. So sometimes the patient actually comes with an INR of more than 5, more than 4, and still patient has PHVT, but on detailed history taking you may come to know that the patient may have missed a few doses, and then to cover it up he takes extra tablets of warfarin, but in the meantime patient already has developed a valve thrombosis. The clinical presentation of this condition is quite varied. It can come to us with progressive dyspnea, it may be an incidental finding, it may just come when you do a routine echo, you find that there are increased gradients across the valve. They may present to us with a thromboembolic event like limb ischemia or a stroke. Severe PHVT typically would present with class 3, class 4 heart failure and cardiogenic shock. Sometimes you may just find it incidentally because you found a new murmur or you have a disappearance of the closing clicks. Again, they may present with they may coexist with an endocarditis, and that is why always we need to rule out endocarditis in these cases. But typically PHVT has normal inflammatory markers. Your ESR, CRP are going to be normal, but your INR is going to be under therapeutic or subtherapeutic. Again, thrombosis is more common in the mitral position as compared to the aortic position. So we have 4 different problems. We have prosthetic valve degeneration, prosthetic valve pannus formation, prosthetic valve thrombosis, and prosthetic valve endocarditis. These all can present in a somewhat similar way. They may be overtly symptomatic, or they may be subclinical. So proper recognition of which of the conditions is actually causing the valvular dysfunction is actually important. Now we know that prosthetic valve dysfunction can present in a variety of ways. Maybe an incidental finding, maybe mildly symptomatic class 1 or class 2, to overt failure and cardiogenic shock. And the type of presentation is actually going to determine your diagnosis. Something that presents very slowly, patient has had increased radiance for a long time, those are likely going to be cases where there is slow pannus formation, whereas somebody who presents acutely is more likely to come to you with either an endocarditis or more likely with a valvular thrombosis. Again, there is another entity known as a patient prosthesis mismatch, or PPM, which is a condition where your gradients are high from the post-operative period, and that is more to do with the small size of the valve or a large size of the patient. So the valve is actually small for the patient. That is why we call it as a patient and a prosthesis mismatch. Patient may be having a very small annulus at the mitral or the aortic position, and that is why the surgeon may have implanted a smaller sized valve, and that is why the patient may have slightly increased radiance. But most of these times these patients are not very symptomatic, and they continue to have increased radiance for a prolonged period of time. Now any patient with a prosthetic valve and coming to us with these symptoms of maybe dyspnea or maybe presenting frankly in failure and shock, we first of all do a 2D echocardiography, right? That is the most important modality to diagnose prosthetic valve thrombosis. And in most of the cases, you are going to find an increase in the transvalvular gradient. So mean gradient across the mitral valve of say more than 5 to 10, and across an aortic valve a mean gradient of more than 40 are considered to be prosthetic heart valve thrombosis. Also, we look at the cuspal thickness, we look at the presence of thrombus, we look at the transprosthetic flow, we look at if there is a valvular regurgitation. These all will guide us in what is the appropriate diagnosis. The independent predictors of valve thrombosis again are increased transvalvular gradients, presence of an occlusive mass on the prosthetic valve, and an INR of less than 2.5. So this is an echocardiographic image where we can see that there is a large vegetation, that there is a large thrombus over the mitral valve. Again, this is a transesophageal image which shows a large thrombus over the mitral valve. So as I said, transthoracic echo is your first diagnostic modality. But the problem with a transthoracic echocardiogram is that there are a lot of artifacts because of the prosthetic mitral or the prosthetic aortic valve, a lot of reverberation artifacts which limit the accurate assessment of the valves. Again, we are going to look at the gradients across the prosthetic valves, maybe the mitral valve and the aortic valve, and if we find that the gradients are high, we are going to look further at the leaflet motions. We are going to look at the presence of a thrombus, look at if there is any pannus formation, and if there is any doubt because of the poor window or suboptimal visualization of these valves, we should go ahead with a transesophageal echocardiogram. So if your TT is suboptimal, you do a transesophageal echo. Also, the problem with TE sometimes is that the accurate discrimination between thrombus in the pannus may be difficult even on a TE. So several studies have been done assessing the role of TE to distinguish between thrombus and a pannus, and again the sensitivity and specificity of TE also is very limited in distinguishing between these two conditions. So the distinction between these two conditions can only be made by a comprehensive assessment which includes a good history, a good clinical examination, and a good echo and a transesophageal echocardiogram. Somebody who comes to us very acutely, very sick, it's more likely going to be prosthetic valve thrombosis. Somebody who has prolonged increase in the gradients across the valve, not very symptomatic or mildly symptomatic, these are going to be patients who have a progressive pannus formation. So again, this is a very important slide, how to distinguish between thrombosis and a pannus. So pathogenesis for a thrombosis is, we know that we have platelet aggregation, whereas in a fibrotic pannus there is thrombin generation, and then there is ultimately collagen deposition. The clinical features are going to determine what is the diagnosis. So in a valve thrombosis, it's a shorter time from valve replacement to valve dysfunction, very important. It's usually within months or maybe a year or two, whereas pannus generally takes 5 to 10 years to develop. The symptoms are going to be acute in a PHVT, whereas they are going to be subclinical or a progressive onset of symptoms in PANUS. INR is going to be usually lower if there is a PHVT, and in a PANUS you are more likely to find a normal INR. Normal means an INR of between 2 to 3. For a thrombus on an echocardiogram, you are going to see that the structure you may see, it may be mobile, it may not be mobile, but it has been seen that it has a higher total mass volume and area as compared to a PANUS. It also has a higher lesion density as compared to a PANUS. And the leaflet motions are going to be restricted in a thrombus, whereas the leaflet motions are going to be normal in case of a PANUS. So, one of the images of a thrombus and restricted leaflet motion of the mitral valve with increased gradients with a mean gradient of 11 across the mitral valve on a transesophageal echocardiogram. Now, one of the most important modalities for diagnosis of a PHVT is a fluoroscopy. So, fluoroscopy is widely available at most cardiac centers. Wherever there is a cath lab available, you can always send these patients. So, echo is good. Fluoroscopy is considered the gold standard for assessment of leaflet motion and the ring motion, because sometimes on an echocardiogram you can see that there are gradients, but the assessment of leaflet mobility may not be good in transthoracic echocardiogram. Even in a transesophageal echocardiogram, you may not be able to assess these things well, whereas the leaflet motion is best appreciated on fluoroscopy and may be considered the gold standard for assessment of prosthetic valve. So, here you confirm what is the leaflet motion, valve mobility, but the problem with fluoroscopy is that the bioprosthetic heart valves and the TTK Chitra valves cannot be assessed with the use of this technique. Again, it is not useful to differentiate between PHVT and PANUS, but mostly in a PANUS you may find that the leaflet mobilities are normal, whereas in PHVT you find that the leaflet mobility is restricted. Opening and the closing angles are defined as the distance between the two angles in open and closing position. So, this is a bileaflet valve, it's a St. Jude Masters series valve, where we have the leaflets, we have the two leaflets, we have the hinge point, and then we have the suture ring. So, fluoroscopy is going to identify what the type of the valve is. It is going to assess your valvular mobility, and it is also going to assess the stability of the ring. If there is a dancing movement of the ring, to and fro movement, you may suspect that the patient has a dehiscence of the prosthetic valve. So, in the figure over here, O is basically the opening angle, C is the closing angle, and E is the total excursion of the leaflets. So, several manufacturers have made valves, and opening and the closing angles of these valves are represented in the slide below. So, the fluoroscopic criteria of valve obstruction are basically restriction of the leaflet motion with calculated opening angle greater than the mean value obtained in the reference population of patients with normally functioning valve. So, I will discuss only the St. Jude Masters series valve, which is the most important valve that we have been using. For a St. Jude Masters series or St. Jude Medical SJM valve, the opening angle should be less than 13 degrees and the closing angle has to be more than 120 degrees. How to assess the patient lies supine, and you just have to do a fluoroscopy. Maybe you obtain 2 or 3 views. For the mitral valve, your best view is the areocranial view, whereas for an aortic valve, your best view is the aleocranial view as well as the areocaudal view. So, mitral valve areocranial and aortic valve aleocranial. So, the figure on the left is basically the opening angle, it's around 18 degrees, and the figure on the right, the B, is the closing angle, it's 130 degrees. So, patients presenting with valve, prosthetic valve dysfunction, we after a clinical examination do 2 of these important modalities, that is a transthoracic echo, maybe a transesophageal echo, and a fluoroscopy. If there is any doubt in these modalities, if there is a discrepancy between the presentation and these findings, we may go ahead with a multi-detector CT. An ECG guided CT can help you assess the leaflet motion and the anatomic assessment of the prosthetic valve in systole and diastole. It can also differentiate between prosthetic valve dysfunction and a patient prosthesis mismatch, because it will help in detecting the thrombus and the PANUS. It can also differentiate between a PANUS and a thrombus depending on the Hounsfield units, but again I am not very sure regarding the exact value of CT in the differentiation between thrombosis and a PANUS formation, because again those Hounsfield units can vary in different cases. So, on the left we have a bioprosthetic valve with a leaflet thickening with subclinical thrombosis. In the middle we have mechanical valve and the bioprosthetic valves with thrombosis, and in the figure on the right we have a bioprosthetic valve PANUS formation. So, differentiation between thrombosis and pannus can be made on the basis of Hounsfield units, with prosthetic valve thrombosis having a lower attenuation value than a pannus formation. Now, how to routinely assess patients who are post valve replacement? So, your screening technique of choice is a transthoracic echocardiogram. We know bioprosthetic valves present earlier, and we need to assess them earlier as compared to the metallic valves. The guidelines say that you should assess these patients with valve replacement only in the presence of signs of valvular dysfunction, and for a bioprosthetic valve it should be only 10 years after valve implantation. However, we know that most of the times these thromboses occur at 1 or 2 years, and that is why early screening is recommended, especially in countries like India, where patients may not take anticoagulation and the rates of PHVT are 6 times higher as compared to the developed countries. Now, if the patient is high risk, post surgery you do a transthoracic at 1 month, and then you do it yearly if the patient does not have any symptoms. If the patient is high risk, then you do it at 1 month, you do it 3 months, 6 months, and then you do it yearly. If your gradients go high, your cusps are thickened, your mobility is restricted, then if any of these are present, then you do further testing in the form of CT, or you do a fluoroscopy. So, post-operative visits for echo typically is at 1 month after valve implantation. On the first visit, it's mostly going to do with your volume status, your heart rhythm, your prosthetic valve function, if your clicks are present, and smooth transitioning to home care. Adherence to the treatment schedule, particularly the vitamin K antagonist therapy like warfarin therapy, adherence to warfarin therapy, INR monitoring are required in the first post-operative month. A focused examination is done at each visit, and instructions regarding antibiotic prophylaxis are repeated. After 6 months, follow-up visits can be conducted either 6 monthly or annually. Post-operatively, so most of the times we are going to do ECG, we are going to do a chest X-ray, we are going to do routine investigations, and we are going to do a transthoracic at 1 month. Now, factors which influence the duration of anticoagulation and the intensity of anticoagulation are most important. Basically, the type of the prosthesis, the thromboembolic risk, and a hemorrhagic risk. Now, several studies have shown that mitral valve is more prone to PHVT as compared to the aortic valve. So, any patient who has a mitral valve, any patient who has a metallic valve in the tricuspid position or a metallic valve in the pulmonary position, any patient who has a prior history of prosthetic heart valve thrombosis, any history of prior thromboembolic events, these are groups of patients who are very high risk for developing prosthetic heart valve thrombosis, and these should be managed with a higher therapeutic INR, maybe 2.5 or even maybe 3, somewhere between 3 and 3.5. Anybody who has had prior PHVT, you should target an INR somewhere between 3 to 3.5. So, post surgery you start the anticoagulation, you call the patient every 3 days, you repeat the INR. Once 2 consecutive INRs are somewhere between 2.5 to 3, then you do it weekly. Once 2 or 3 repeated INRs are in the therapeutic range every weekly, then you do it monthly. Continue this regimen for the first 3 months, and once the patient is stable, patient is already post valve replacement for 3 months, your INRs are fine for the last 2 months, and that is when you can do your monitoring every 3 monthly. So, the recommendations of antithrombotic therapy after valve replacement from the American College of Cardiology are basically target an INR of 2.5 for the aortic valve with no risk factors for thromboembolism, INR of 3 for aortic valve with risk factors like LV dysfunction or atrial fibrillation, or for a mitral valve again an INR of around 3, plus we need to give them 75 milligrams of aspirin, which is a class 1 recommendation. So, these are guidelines for a metallic heart valve. For a surgically placed bioprosthetic valve, we give them warfarin with an INR target of 2.5 plus aspirin for the first 3 months, and then we stop warfarin and shift these patients to lifelong aspirin 75 to 100 milligrams. For TAVR, we know that we give these patients dual antiplatelet therapy, a clopidogrel 75 with an aspirin of either 75 or 150 for 6 months, and then maybe we can shift them to single antiplatelet therapy. So, for a metallic valve, if it's a mitral valve, an INR target of 3, if it's an aortic valve uncomplicated patient, 2.5, if it's an aortic valve with risk factors like AF or LV dysfunction or a prior thromboembolic event, then we target an INR of 3. And for surgically implanted bioprosthetic heart valve, we give them short duration of anticoagulation and aspirin followed by lifelong aspirin therapy. In pregnancy, In the first trimester, warfarin can be continued if the requirement of warfarin is less than 5 mg per day, and at 36 weeks you shift these patients from warfarin to low molecular weight heparin. How do we manage prosthetic valve thrombosis? It's a life-threatening condition. We've seen that mortality can range from 10 to 30%. Prompt treatment, that is why, is mandatory. The etiology of PHVT is very important because it is going to help us in preventing further episodes of PHVT. So 3 options: surgery, thrombolysis and anticoagulation. We see guidelines. Patient who comes with class 3, class 4 heart failure or cardiogenic shock, the treatment of choice is surgery. Again, emergency surgery is indicated for patients who have a left-sided prosthetic heart valve thrombosis with a large thrombus, a thrombus burden of more than 0.8 square centimeters. So these are 2 classic indications of surgery: class 3, class 4 presentation, or a thrombus burden of more than 0.8 centimeters square. Recent onset PHVT, class 1, class 2 symptoms may be considered for surgery, again a 2A recommendation. And for a thrombosed right-sided prosthetic heart valve, you may consider thrombolysis, again a class 2A recommendation. So NYHA class 3, class 4 mobile clot are indications for surgery. Right-sided valves and NYHA class 1, 2 are indications for fibrinolytic therapy. What factors favor surgery? If surgery is readily available, the surgical risk is low. Patient is in class 4 or class 3. If the thrombus burden is very large, if the patient needs surgery for some other indication like a concomitant CAD, if the patient has developed a PANUS, these are indications that the patient goes for surgery. However, if the patient is class 1, class 2 mobile, the thrombus burden is not very large, it's not very mobile, and the risk for thrombolysis is low, then the patient may be considered for a thrombolytic therapy. Right? So if you have a suspected transcatheter prosthetic valve thrombosis, we are going to evaluate these patients for with an echocardiogram, a transthoracic and a transesophageal echocardiogram, and if required, surgery. If the patient is hemodynamically unstable, then these patients are again going to go for surgery. If the patient is hemodynamically stable, class 1, class 2, then these groups of patients are going to favorably go towards thrombolysis. The success of thrombolysis is defined as 75% reduction in the largest diameter of the thrombus, return of the transvalvular gradients to a normal range, and a partial success is defined as a partial improvement in transvalvular gradient, and a failed thrombolysis is defined as no reduction in the transvalvular gradient. Several modalities for thrombolysis are available. What we've been using traditionally is tissue plasminogen activator, or TPA, in the form of alteplase. There are several studies which have shown that a slow thrombolysis may be beneficial as compared to rapid infusion of a thrombolytic, and a 25 mg of TPA over 25 hours has shown an overall success rate of more than 90%. So, and the complication rate was around 6.5%. Right. So, if we have a prosthetic heart valve thrombosis, if the patient, if we have justification for doing thrombolysis, we should ideally wait for an INR to be less than 2.5. Once the INR is less than 2.5, we give 25 mg of TP over 25 hours and we repeat an evaluation. If the obstruction has been resolved, then we just switch the patient to warfarin plus heparin. If the total thrombus burden, more than 10 millimeter, if thrombolytic is justified, again we wait till the INR is less than 2.5. We give them slow dose of TPA 25 mg and we proceed for transesophageal echocardiogram. If we see complete success with thrombolysis, we stop the TPA, give them heparin plus warfarin. However, if we have just partial success, then we may need to continue TPA. We can give 25 milligrams over 25 hours to a total dose of 200 milligrams. Right? So sometimes we do come across patients who have deranged coagulation parameters, say an INR of more than 3 with a prosthetic heart valve thrombosis, and that is when we also need to take it into account the deranged coagulation parameters. So if your INR is less than 2.5, we can straight ahead proceed with thrombolytic. If the INR is more than 3, again the data is very limited, but we personally what we've been doing is we give them FFP transfusions, and then once the INR is less than 2.5, we then go ahead with thrombolytic therapy. So several studies have been conducted which assess the role of thrombolytic therapy as compared to surgery, and what has been shown in multiple studies is the patient is sick, class 3, class 4 will obviously go for surgery. If the patient is stable, class 1, class 2, a low small thrombus burden, that is when you are going to go with a fibrinolytic therapy. The different types of fibrinolytics that have been used includes streptokinase, urokinase and tissue plasminogen activators. Now, streptokinase has been studied in 2 doses, 1.5 lakh unit over 1 hour, and the conventional regimen of 2.5 lakh unit bolus followed by 1 lakh unit per hour infusion. Both of these have been shown to be good. Both of these show a good success rate of around 60% as compared to TPA, which gives a success rate of almost 80 to 90%. The other drugs which have been used include urokinase and tissue plasminogen activators. So urokinase again has been studied as a bolus dose of 2,50,000 units followed by 1 lakh unit per hour for a period of 10 hours and then followed by low molecular weight heparin. The dose of urokinase has ranged from 2 million units to 5 million units. It can be continued for a period of 36 to 48 hours, and hence it has been studied almost starting from doses of 1.5 million to 5 million units. Urokinase again is still used commonly in clinical practice in China because of the low cost of urokinase and the excessive costs of tissue plasminogen activators. Studies have shown that urokinase is less effective in the treatment of PHVT than streptokinase or TPAs, and the major complications are basically hemorrhage and thromboembolism. So to conclude, prosthetic heart valve thrombosis is a problem which is common to both developed and the developing countries, but it is more of a problem with developing countries, particularly because of the increased treatment costs, poor compliance of the patients, and we've seen that prosthetic valve thrombosis rates are almost 6 times higher in our country as compared to the developed countries. So with a large number of patients undergoing valve replacements and almost a 6% per patient year rates of prosthetic valve thrombosis, we know that we are going to come across a lot of patients with PHVT, and we know that the mortality rates of PHVT are quite high, and also the rates of systemic embolization are quite high, and that is why appropriate treatment of prosthetic heart valve thrombosis is important. A multidisciplinary team approach which consists of the cardiologists as well as the cardiac surgeons is extremely important for the management of this important entity, because the surgeons also face problems when they have to go ahead with a repeat surgery, especially if the patient has undergone a surgery in the near future. That is why it is important to individualize the treatment for every patient, taking into account the duration of the surgery, what is the anticoagulation status, and what is the clinical status, what the NYHA class of the patient is, right? So for a sick patient, again, surgery is still the treatment of choice. Somebody who comes in class 3 or in cardiogenic shock, surgery is the preferred option. But for somebody who is class 1 or class 2 and the thrombus burden is small, these are groups of patients who may benefit with a thrombolytic therapy. Again, we need to remember that thrombolytic therapy is associated with serious complications like systemic embolization and hemorrhagic complications like intracranial bleed or some other major bleeds. The 30-day mortality of surgery for PHVT is almost 10 to 15%, but the rates go down in patients who have class 1 or 2 symptoms. And the results of the fibrinolytic therapy also show that the 30-day mortality is around 7% and the hemodynamic success rate is around 70%. So with streptokinase it is around 60%, with an altiplase it's around 90%. So we usually have an average success of around 75%. 1 in 4 patients who receive thrombolytic may not improve and may need a redo surgery. And again, we know that the thromboembolic event rates are quite high and also the major bleeding event rates are quite high. And so appropriate monitoring of patients who are on thrombolytics is also very important. When a patient is receiving a thrombolytic therapy, all other forms of antiplatelets and anticoagulation should be stopped, or heparin as well as aspirin should be stopped in these groups of patients. But it's important to remember that somebody who comes sick, usually these subgroups of patients should be considered for surgery. And another very important point is the prevention of PHVT. Patients should be adequately counseled regarding maintenance of INR. They should have a booklet which monitors INR every weekly for the first few weeks after surgery, every monthly for the first 3 to 6 months after surgery, and maybe once the INR is stable for 3 to 6 months, then these groups of patients may be considered for 3 monthly monitoring of INR. Thank you.